Welcome to the Ruddle Show. I'm Lisette, and this is my dad, Cliff Ruddle. Are you excited about today's show?
Yeah, the red flags.
So we found a list called 9 Dental Red Flags, and it's a list of warning signs to alert the patients that if you see these things in the dental office you have chosen, you might want to rethink your choice. So it's also a useful list, though, for dentists because you will surely want to avoid these red flags so you can offer the best possible dental environment and be of maximum service to them. So here's the list behind me. And a lot of these things on the list are pretty obvious why they're red flags. But I'm going to go through the list, and you can, if you want to provide some commentary, go ahead. If you think it's just self-explanatory, you can say self-explanatory.
Well, I actually had about an hour comment on each one of them.
Okay, well, Lori will not be happy about that, but let's just do the best we can. Okay, so the first thing, dental records are not requested. Your old dental records.
Sloppy.
Okay. The office is using old technology.
Wrong office. Well, you know, within common sense, I mean, I have family members that changed their dentist because they didn't go to digital about 500 years ago.
Yeah, and also, you know, you might think, well, I'm a patient, how would I know how old that technology is? Well, you can kind of get an idea of how the office feels. Does it feel like office, or does it feel like
absolutely.
you went back in the past 50 years ago?
Yeah, if you see the dentist back there spinning his legs to make the turban go so he can grind on your teeth, yes.
Okay, red flag number 3, the sterile protocol is broken.
No hands to the mouth, the lips, the hair, the nose are on the floor.
If you can even get through the PPE.
That's true.
Okay, number 4, you have to ask for oral cancer screenings.
That's a red flag. That should be automatic.
Okay. Overzealous about extensive work.
Trying to hit their numbers.
Their reputation is negative.
Why are you in that office?
I do want to add one thing. I go to a dermatologist, and I've heard other people around town say that he's not a nice person. I think he's a very great dermatologist, but he doesn't maybe have
the chairside manner.
Right. So that is an issue. Okay.
So at the end of the day, really good than really nice.
I'm going there because he's a dermatologist, not because I want him to be my friend.
I really like him.
Okay, number 7, they don't show their work.
I've just noticed over the years that people that show their work are proud of their work.
Right. Number 8, they hard sell capture crowns.
Well, it could come across as a little greedy. I mean, it's fine to recommend work that needs to be done, but there doesn't need to be artificial urgency. You just
Right. And the last one, they treat you like an account number.
Well, I think we want to go into an office where we feel energy, we feel excitement, we feel enthusiasm. We want for service, or what do you call it, concierge service. We want ultimate experience. We want a premium experience. So, yeah, I don't want to walk in the office and they go, he'll be right with you. Have a seat. I'd like him to look up, see me, and say how nice it is. If it's a pain in the ass.
Yeah, it's when I go into just various offices, usually I find that they actually greet me by name. And I'm surprised that they know my name, but they probably have my chart right there. They know I'm coming in. But I always feel like, wow, they know my name. So
But that's neat, though, what you just said.
Yeah. So, okay, well, is there anything you would add to this list? And I should tell you that this list is from 2018, so it's pre-COVID. But probably a lot of COVID-related issues would fall under the sterile protocol. But is there anything that you would add to this list?
Actually taught to do in grad school back in the 70s is go sit in your own operatory for about 1 to 2 minutes once a week. And you'll see things that you didn't know were there, even though you're cleaning all the counters and you're doing all the usual stuff. It's just nice to become the patient and have role reversal and see what they're seeing through their eyes. Because, you know, when they're first seated, that might leave, do this. There's a lot of busyness and activity, and they're left alone. So I don't like anybody ever left alone. I want conversations always going, even if it's small talk, making connections. It relaxes people.
Yeah, I think that for me, if I'm going to an office and every time I go to the office, I have to wait in the waiting room for a minimum of 30 minutes, I find that to be a little bit annoying. But
try to be on time.
Okay, well, so just some things to think about. You want your patient to feel comfortable in the best possible hands. So if you see areas that your office could improve on, then by all means do it.
I don't know if this is going to work anymore because of COVID and where we are with this infectious control, but we used to give patients office tours. Mm-hmm. And there was like 3 tours. One was like, there's the bathroom, and there's where you get coffee, and there's the refrigerator, get some juice. Then there was another tour where we would show them operatories, and then the full tour was sterilization, the whole thing. I mean, you're proud of it. It's kind of like when you're going to go Airbnb and you go on a virtual tour and you find out your hotel room.
I guess if part of the tour is viewing the dark room, then maybe you're in the wrong office.
That's pretty good. Be careful about the dark room experience.
Okay, well, we have a great show for you today, so let's get going on it. Joined by a guest endodontist, Dr. Randy Cross, who is first going to give a presentation about an endodontic invention he is working on, and then he's going to join us via Zoom to answer some questions. So we are very enthusiastic about today's show, and I know you especially are very excited about his invention. I think he's told me, a few times now that it's one of the most exciting things that he's seen as far as endodontic inventions go. Of practicing. So why don't you tell us a little bit about Dr. Cross, how you met him, and maybe tell us a little bit about what he's working on.
Sure. Well, for those who don't know Dr. Randy Cross, he's married, has 2 kids, lives in Santa Cruz, went to UC Davis, University of California, Davis, and got his biochemistry degree. Then he went on to the University of California, San Francisco, where you were born, dental degree, and then he worked for 10 years in the field as a general practitioner, and he was the director of 2 clinics for that 10-year period, and then he went to the University of Southern California, USC, we say. He's a Trojan man. So anyway...
to become an endodontist, right?
Yeah, I think we learned that he's going to graduate this Friday, and he'll have finished his postgraduate work as an endodontist. So that's cool. I met him, to answer that question, I met him at Ruddle with the Residents program that years ago, and he was one of the kids out there in the audience, and we connected. And then what we connected on was his new innovation. His idea at that time was just a concept about a chairside method to determine the level of remaining bacterial load with a biomarker. So that was very impressive.
And that actually brings us to the topic of his presentation. So we're going to watch that first, and it's about 12, 13 minutes. We'll watch that, and then he's going to join us via Zoom, and we'll ask him some questions. So here's the movie.
Hey everybody, this is Randolph Cross, and we talk about biomarkers and endodontics. Before I do, I just want to say it's a huge honor to be at Dr. Ruddle's show. He's a legend in the endodontic community. He's given so much. So again, thank you, Dr. Ruddle, for having me on. In the past, we used to do cell culturing. It fell out of fashion for many reasons. And I think what the future will be is a biomarker, just a quick, easy way to find out, is my root canal clean, to have a good prognosis before I close up the case. I do want to put a word of warning out there. This is very cutting edge. This needs to be backed by clinical research. This is my findings in a small subset of patients. So, just take everything I say with a grain of salt. But I think it's super exciting. I'm very passionate about it, and I'm just really excited to be talking to you all today. Hey everybody, so as a general outline for today, we're going to talk about, what seems to be important when you're doing a root canal. We're going to look at some of the past research to show how effective biomarkers are and cell culturing is to see when a root canal is clean and what that actually means. And then we're going to go ahead and look at some of my findings to see what are some general trends in biomarkers and what you can expect from using a biomarker for your root canals. In this picture, there's Cliff in the middle, back right, and this is Ruddle at the residence at the start of my residency. And I just thought it was so cool that during his presentation, he's talking about being able to determine when a root canal is clean. And here we are a year and a half later, and I'm presenting what I've used to determine when my root canals are clean. So it's pretty neat. When you look at what's important in a root canal, a lot of the things are beyond your control as an endodontist. You can't control the health of the patient before they sit in your chair, the size of the lesion, is it necrotic or vital? And a lot of times you don't even have to say in their restoration too. You don't know when they're going to go to the dentist to get it crowned. And it was interesting when you looked at the research, because you would think that, are you short or long at the apex? What filling technique are you using? How's your filling quality look? Radiographically, how does it look? You think those would be huge factors in determining root canal success. But the research shows that it's probably important, but it's just not as important as you would think. What always seemed to be important is, did you find all the anatomy? Did you get down the canals? You're not missing a canal. And also, were the canals clean when you sealed the case? It seems like those are the two biggest factors to making sure that your root canal is successful. Did you find everything, and did you clean everything? So in the past, they used to culture bacteria from the root canals before closing the case. And some studies would show very different outcomes if there's bacteria in there. If it didn't have bacteria, it would have a 80 to 94% success rate. If it did have bacteria when you sealed up the root canal, it could have a 44 to 68% success rate. More recently, they've been using a biomarker calcine to show when the root canal is clean or not. If there's high levels of that biomarker, it's rated 20%. If there's low levels of that biomarkers, it has a 90% success. So, there is significance to, is the root canal clean or not before you fill it. But the problem is, both of these are time consuming and nobody really does it anymore. If you did have a quick, easy biomarker, I think it kind of opens up a whole world in endodontics. It means that you could just test your root canal to make sure it's clean before you filled it. If it's not clean, just clean it some more. Maybe you could go ahead and, you can be conservative for the cleaner root canals and take it up to a larger file size for the dirty ones. Maybe you don't have to do 2 as an endo. You just let the bleach soak a little bit longer. You hit it with the endo activator, ultrasonic, or whatever you choose to do to clean it out. Maybe you don't have to do as many 2 visit endos. And also an interesting dynamic of, okay, well, you have an old root canal, it looks great, but then the filling leaked. There's the cotton roll got infected, whatever happens to your old root canal. But now, as opposed to just arbitrarily decide you retreat it or not, if you had a biomarker, you could just look and see if there's bacteria by the tooth. So I think there's a lot of really cool practical applications to it. And when you look at a perfect biomarker, it would be easy to use, easy enough for resident to use. It would be cheap. It would be reliable, give you very reliable data. Versatile, use it necrotic, vital, retreat cases. It'd be sensitive. It would detect less than 1 living bacteria in the cell, and also be portable. It shouldn't be a CBCT. It shouldn't be a centrifuge. It should be easy. And then when I looked at some biomarkers, I found a great one. In the graph on the right, I got some teeth extracted and cleaned it out. And you can see, as you go in a bigger file size and these extracted teeth, this biomarker goes down and down and down. And the other kind of interesting thing you can see is that different teeth get cleaner at different rates. So maybe not everything is a 2504. Maybe not everything is an F5. Maybe you can go ahead and gauge this, the size of your file to how dirty the root canal is. And I think we all want this picture on the right. We all want a tooth with a lesion to heal. And I think that's why this biomarker could be so good. It basically takes a lot of the guesswork out of your root canals. You know when it's clean and you know it can fill it, and be sure that the bacteria is removed. So I don't think it's only a benefit to the patient, but it's also a benefit to the dentist. You know when the canal is clean. It takes a lot of the guesswork out. If you want to finish in smaller files, great. You now have a tool to use to know when that canal is clean without having to remove all that tooth structure. You can also look for outliers too. We all know there's bacteria, there's in the fractures and cracks and perforations and things like that. And now you have a test to see, is this tooth abnormally high in biomarker? And I mentioned an ideal biomarker would be really easy to use, and that's what this is. It takes about a minute. Once you want to take stop and check for the cellular debris, you go ahead and you rinse the tooth with sterile saline. You put a hand file in there just to agitate the walls for about 5 seconds. You put in a paper point, you throw it in the tester, you squirt in the chemical, and then you put it in your reader. And in 10 seconds later, you get a result. Now, the really cool part about this presentation is looking at some of the data from me using this biomarker. And some of it's surprising, some of it's what you expect. So on here, we can see that, at the beginning of the root canal, the hand files, you have a lot of biomarker present. When you're done instrumenting, you still have a lot, but less. And then right before you finish the root canal, after all your irrigation, it's not zero, but you have a lot cleaner, but it's still there. I think that's the most surprising part with these root canals is that look at bacterial levels goes from 1 million to 1, 1 million to 0. When you look at this biomarker for cellular debris, it's still there. There's still bacteria remnants, biofilm in these canals. It's just a lot less. When you look at the findings as a whole, the results are pretty interesting. Like some of them are as you expect. Vital case was easier to clean than a necrotic case, which was easier than a retreat case. Some things are kind of new, didn't expect, and that was that there's the findings between molar, premolar, and anterior and biomarker are pretty similar. I thought the molar would have had more, and that could just be from my small sample size. And the other kind of interesting thing was that it doesn't remove all the bacteria. It doesn't remove all the biomarker. So in the cases here is that my 1 visit endos were a lot cleaner than my 2 visits. That being said, because I have testing for biomarker, I would usually just 2 visit the ones that were a little more dirty. So I don't think that putting medication in makes the tooth more dirty, but just that by having a biomarker, I know which teeth that I need to, throw the kitchen sink at to get clean. The really interesting piece is when you look at the individual results, it's extremely variable. And it seems like there'd be these outliers. And what was interesting is those outliers tend to be the ones that failed. They tend to be the ones that had perforations, that had a vertical root fracture, that had an open margin. It was really neat that you can get same day 1 minute feedback on just something that just seems peculiar about the case. This next graph, I just removed those top 15%. So, okay, let's ignore those ones that are really high. What do the other ones look like? And you just get the same answer. It's just extremely variable. So even if you remove those top findings that just something's going on with the tooth, you still get these levels that are very high and very low. And what's kind of neat is if you get a level that's high, it's not the end of the world. You go ahead and you put more bleach in, you do your ultrasonic, you leave the room for 20 minutes, whatever your preferred the tooth is. By doing that, you bring down that biomarker level. And we'll see, but it seems like that would make the canal more successful. At least for me, what it also does is if I have a case of the sinus tract, I have a case that's percussion sensitive, I have a case that in the past you'd think you'd have to 2 visit this. Well, this biomarker, you've done everything inside of that root to get it clean. So why not just finish it the same day? It takes a lot. So the findings are pretty neat. It's that each tooth is extremely variable. Some teeth are going to be dirty when you measure for biomarker and some are going to be clean. If they're high, then you can go ahead and just further activate, further irrigate. And my findings suggest that if you do a 5-minute activation irrigation round, you reduce those levels by 32%. So it doesn't completely disappear, but it takes a lot of the guesswork out of how much you have to clean it. When I get those really, really high numbers, It's usually something's weird. It's a tooth that's gonna fail. It has a vertical root fracture, it has an open margin. It's just something's weird about the tooth. And it's neat to know that before you finish the root canal, before the patient pays, before the patient gets a crown, before this awkward moment comes in after the patient's already gone. It also, if there's an old root canal that got exposed to saliva without using the Schmidt decision tree and these arbitrary guidelines of how long is the saliva there? How does the root canal look? How does the filling look? It's just a patient's tooth findings of there's bacteria on the root canal and there's not. So I think for me, it helps me gauge, do I redo the root canal with an actual individual finding for that patient? If there's saliva on the root canal, it may not be a big deal, or it might be, but at least this gives you another tool to find out what to do for those cases. And the other really interesting thing is, we've always judged root canals in the past on how does the white line look in the radiograph? How does it look good? Is a root canal short or long the apex? Maybe what's more important than that is how much biomarker, how much cellular debris, how much viable bacteria is in the root canal. Here's some of the sources that I pulled from to put this document together. Again, thank you, Dr. Ruddle, for being a wealth of knowledge, being so inspirational, and just kind of guiding me and really helping me along the way, because you had faith in this kind of project from the very beginning, and I don't think people know how much you really helped me out. I also want to thank my wife, Audrey. For the last 2 years, Monday through Friday, she's been watching the kids as I finish my residency, so I'm just so in debt to you. The other thing I want to mention before I go is just, please, if anyone's out there is interested in researching this topic, huge potential, send me an email. So if you're a resident, faculty, whatever, if you're looking in to get some research and try to figure out, your new system, or, kind of you want to test out something and have a quick, easy, cheap way of doing it, that's what this biomarker does. My email is ddscross@gmail.com. So please feel free to shoot me an email in case you guys want to, help out some research in this area.
Okay, so now we have Dr. Randolph Cross here joining us by Zoom. So thank you for joining us, and that was a really excellent presentation. Thanks for putting that together.
No worries. Thank you.
Yeah, Randy, I've really been telling my family a lot about you, because when I first heard this idea from you, this concept of yours, I have said this, and maybe I'm getting tired of saying it, or you're getting tired of hearing it, but I think it's the most important method or invention that has happened in my almost 50 years of being involved in clinical dentistry. So it's just a delight to have you here, and we probably have a few questions. Is that okay?
That would be fantastic. Yeah, I'd love to try to answer those for you guys.
Great.
Okay, well, the first question I had from watching the presentation, you're calling the product the Endocator on the presentation, but that's probably like not a permanent name yet. But what is it? Is it a tester device and a solution? And can you tell us what the solution is, or is that information proprietary?
Yeah, we're still working out some of the details, but kind of the general overview. So, in endodontics, you draw out the canal with a paper point, you just throw it in the trash and you fill the canal. So with my device, you put in the paper point, as opposed to throwing it away, you put it in this little tester. And the reagents are pre-measured, so there's no science or anything like that involved. You just kind of squirt in the enzyme, and you're not going to be able to see it with your naked eye, but it's creating a little signal. And so putting the paper point, after putting it in the tester, you put it in my device to read that signal. So the whole process takes about a minute, and it'll kind of give you feedback on how much cellular debris is present in that root canal. Yeah.
Randy, this seems like a huge advancement. I don't want to date myself, but back in the 70s, we were doing culturing with paper points. And we used to laugh and say, well, did we really think that the bug would jump out of the lateral canal and leap onto my paper point so I could get a negative culture? And it seems like since then, over the last 50 years, this is really sophisticated. It's bringing us into biomedicine.
Yeah, and it's individualized care too. It's no longer this broad necrotic outcomes and vital outcomes, like this specific tooth, how much cellular debris is present. And the other thing I like about this is I've done some culturing. It's really hard. Like I'll get positive results and things I shouldn't get positive results on, and negative results when, for almost every case, and it's black and white. It's 10,000 shades of gray where you can see exactly how dirty it is. You get feedback in a minute. So it's not like you seal the case and you can't do anything else about it. You can go ahead and hit it with the endovactivator. You can let the bleach soak longer. You can close it up. You can, if you're working on 2 teeth, finish 1 tooth and let the bleach soak in the other one, then come back and finish the other one and kind of time it so that, you're providing individualized care for this patient. So it's pretty neat. It's pretty cool. And it's super easy. It's not like culturing. It's just 3 buttons and results, and then you can act on it. And yes, it seems really much more accurate than culturing.
Well, I'm just wondering how you came up with this idea and maybe how others haven't come up with it before you now, because apparently you have a background in biochemistry, and this probably influenced your interest in using biomarkers to track endodontic infection. But what sparked the idea for you?
Yeah, it was kind of funny. So I have a background in biochem, and I actually worked in a biochem lab for a year. So culturing and things like that wasn't really. So, I had a background in ELISA assays and things like that. But what got me was just finals week of first year, winter. I'm like, there's got to be a better way. We're learning about Schrögen and SpongeFest and the importance of it being a clean canal, was it dirty and bacteria positive, negative. And I'm like, there's all this information to show how important to have a clean canal is, but there's nothing to actually kind of figure that out. I'm like, there's got to be a way to figure this out. So I went ahead and found a biomarker that I think would be perfect for it. It can detect vital teeth, it can detect necrotic teeth, fragile. So after a couple days, it's not going to be present. So it's not detecting like, PCR, which, old traces of DNA. This has to be live fairly recently for it to get detected. I'm just like, I went up to my wife, I'm like, hey, this is going to be crazy. I know we're broke. I know I'm in residency, but for my Christmas present, can you go ahead and buy me this lab device? And she went ahead and got it. And I'm expecting it not to work. I'm expecting it not to be sensitive enough because it's only a minute. It shouldn't be able to get good results in a minute. And she get extracted tooth. I clean it. I see it gets cleaner. And what blows my mind is just that it's not even like it's barely detecting it. It's like a very detectable signal that gets cleaner as you clean the canal. It's just really easy to use, and it works out really well. So yeah, it's just it's been quite a ride, quite a journey.
Well, have you figured out how clean is clean enough yet, or is that still evolving?
I think that's still evolving. I think that way of cleaning the tooth, irrigating it, and testing it. And I know when I kind of test it with other people, or maybe the pre-doc clinics that don't have the endoactivator, don't have advanced irrigating systems that we do, you get different results. So I think we need to get not just how I use it and my levels. I think we have to get more people using this to really find out what levels are safe to close a tooth. But that being said, if I get high levels, for the most part, you just clean it up and get it lower. But if I get high levels and I can't really clean it that much, put red flags in my treatment, and then it can suggest if the tooth's going to fail or not. So I have my results dialed in, but I think we have to get other people using it to make sure that how I use it is similar to their results as well.
Well, Randy, what would be some of the outliers that you might, if you get like a crazy reading that it's completely not consistent with your experience, what are some of the things you're looking for?
Interesting part too. So for the most part, if I get a little bit higher reading, then I just clean it some more and it gets cleaner. The outliers are ones that I clean it and it doesn't really get clean, or only gets clean a little bit more. So kind of some of the examples I've had are like it's perforations, vertical root fractures, and also just teeth that I know that just don't seem to work. So most recently I finished a case, we ended up testing for the result afterwards, and it was a sky high. Sure enough, the patient's coming back, and I think the tooth's going to have to be extracted. So I have one-off cases where it just seems high levels, and it just, for the most part, if you seal it in those high levels, it doesn't seem to work out. So I have my results dialed in, and I'm hoping other people have similar findings as well.
That was one thing that I thought was very interesting in your presentation, that if you keep getting high levels, then maybe you need to be looking for something else before continuing on with the case. Maybe there's a or an open margin or something. So that was very intriguing to me.
Yeah, and it's great to figure that out beforehand, before you seal up the root canal, before you put a crown on it, and before you then have to go ahead and open everything up again. So it's great. And the other interesting thing too is like sometimes these levels get low, and it's not like you'd expect them to be low. So maybe the patient has a sinus tract, and in the past you're like, well, I can't close this up because they have a sinus tract. But if my results are telling you it's clean inside the tooth, at least for me, I'm confident it's clean inside the tooth, so just close it up. Why bring it back if you've done everything inside the tooth to clean it out?
Did you want to add anything, Dad, about that?
Well, I'm just so impressed because, Randy, for a lot of decades of my practice, I was known for non-surgical retreatment or surgical retreatment, but revisional treatment. And there's a lot of missed canals. So it'd be pretty interesting if this could pick up maybe missed canal.
That is fairly interesting. And I think it just depends. If there's a lot of fins into one of the canals you're testing, I can see how that would have higher levels. If it's a totally separate canal, it'd be interesting. And I think that's where we need more research. Just a lot of these questions, this would be great to have answered. And I think this is a great answer for if you're in the canal, making sure it's clean enough. But there's those other questions like, well, what happens if there's a missed canal? Can this start detecting those? And the answer to that is I have no idea. It'd be really interesting to find out, though.
So, Randy, was it even possible keep this device, in your own territory? I imagine there was tremendous infighting on campus for every student in the post-grad program, and you have big classes. They must have been trying to get that out of your locker and steal it.
It's been pretty exciting. I mean, I think that the best story I have with, other people using it is, I think it's a Seltzer and Bender cognitive dissonance. Like, why does a great looking... So I used it. So we're overseeing some, we both have our patients. We then go ahead and we test our patients. And the root canal where I was helping out a student with, it looked pretty good, but there's a little tiny void in the apical third. So, I could see a lot of people critiquing that and saying, oh, that's not good. That's not good. And, maybe, but my other friend, he finished his root canal. Beautiful. It looked perfect. Filled all the way to the apical. Great. It was just a fantastic root canal. But then we compared test levels, and my root canal had 10% the biomarker that his did. So we always wonder, like, why does this root canal fail? It looks great. Well, if you seal in 10 times the amount of food for the reinfection than mine, which has 10% less, I mean, it's obvious. So, I mean, I think we put so much emphasis on these white lines in the root canal when the biggest, or are you 0.5 millimeter short, you're 0.5 millimeter long? I think a bigger, kind of curveball is how much reinfection, what is the likelihood of you left live bacteria in there based on a biomarker present? So I think that's been a bigger question.
I like that a lot
in
your
question.
Presentation, Randy, where you said, filled to the terminus, dense pack, maybe, and you gave all these things, but it was really neat how you identified, just like one example was restoration of the endodontically treated tooth. That was a big deal.
Yeah. And I think all those things are important, but I think when you try to look at it from like a completely clean tooth, I think you got to make those even. So I think if you have a tooth that's clean the same and you have one that's short of the apex or long of the apex, or one with the restoration or without, I mean, I think you got to equal those out in order to get those findings. So I'm not trying to say that those other things aren't important, but I think what's way more important, did you clean the tooth before you sealed it? So I think for me, that's the most important thing.
Okay, well, right now, why don't we show a video? We have a 1-minute demo video of you using the product. So let's watch that now.
I want to go ahead and demonstrate what the cellular debris testing looks like. Here I have a cleaned up tooth. First, I'm going to rinse it with water to remove all of the disinfectants. Next, I'm going to get a hand file to scrape the walls and get a better sample. Next, use a paper point to go ahead and transfer that sample from the tooth to the tester. I'm going to go ahead and squirt in the reagents and then load that tester into my device to go ahead and get a measurement. You can see it's pretty easy. It takes about a minute. The neat thing about it is it's so quick. In case you get a high reading, you just let the bleach soak longer. You can hit it with another round of the endo activator. You can go ahead and bring it back for 2 visits really high. In this case, the tooth was clean, so we go ahead and close up the case.
So it seems really simple to use and that you could easily integrate it into pretty much every case.
Yeah, and since I've kind of come up with the concept, that's basically what I do. And then the neat thing is I usually just use it once. I do my normal routine, I clean it out, and I test it at the end. And if it's clean, I seal it. If it's not quite clean, I put the sodium hypochlorite and activate it one more time. And then if it's starting to use really high numbers, that's when I have to do, maybe a second test or even a third test just to make sure it's clean. But for the most part, I just do like a final check before I finish the case.
So where does the project stand right now? I mean, I know that you filed some patents and some have been granted, some are patent pending still, and are you working with the company? Are you getting more research done on it? Where does it stand now?
Yeah, so it's just moving along. So it's kind of, we're getting the formula down. Like the generic formula works okay, but we want to add more buffers for the higher disinfectants. We want to have something custom for the endodontic cavity. So right now I'm just kind of working with a couple companies to make sure that when it gets released, the perfect version, and just really work out well for the endodontic community.
Mm-hmm. Randy, I noticed that because we've talked about this for, I don't know, is it fair to say well over a year? Maybe almost 2?
Yeah, right about.
And it seems like I've learned a lot from you, so I want to acknowledge that to the audience. I'm the student, and I'm learning from Randy Cross. But anyway, we have these numbers that you recite, and I was you and I've had discussions. Maybe when we come to market, have it in some kind of an easy scale of 0 to 10 or 0 to 100, because cowboys like me, when you started to say this much loads left, I'm going like, whoa, is that going to be okay? But then you tell me it's relative to a much bigger number.
Yeah, so that's definitely true. It's right now it's trying to interpret these numbers, and I know what those numbers are, but I want to make this easy for everybody. So yeah, the goal is to go ahead and get these scales in the thousands and things like that, and get to a simple 1 to 10, 1 to 100 scale. So yeah, we're easier to interpret at this point.
It seems that this could just change the whole standard of care, because if you can assign a level of cleanliness that becomes a new standard, then it seems to me that it would be unethical to finish and pack a case if it hasn't met that benchmark. So that's just pretty amazing to me.
Yeah, I mean, it does bring up that consideration, especially if you're going to put like a, $5,000 bridge on top of the tooth, and then you're in a debate, do I retreat it or not retreat it? Well, with these results, quantitatively now, okay, I clean inside the canal as best I can. Maybe I have to do something else. Maybe it's time for a surgery. And it just kind of gets rid of all that questions in your head. So I've had cases where it still hurts the patient afterwards, or something happens and I didn't test it. In the back of my mind, I'm just wondering, like, there's 1,000 things going through my mind. With this device, I know that I cleaned everything I possibly could inside the canal. And when I do that, it seems like there's bone healing, there's signs of healing. So it just makes it really easy. And I think it's a good point. It's just that, might as well make sure you clean the canal enough before you seal the case.
Well, if I purchased one of these things and started using it, I guess I'd have to categorize my caseload as pre-Randy and post-Randy.
Yeah. Well, and the other hard part is you get competitive. You're like, no, I can't seal off of this. I can do a little bit more. I can do this. I mean, you almost get competitive on yourself to try to make it as clean as possible. Yeah. And the other thing is, like, some teeth are going to be clean, some are going to be dirty. You can't feel bad about that. You can't feel bad that it's a necrotic tooth that's bacteria has been for 10 years. Going to be higher than your vital tooth. You can't feel bad that the retreat case wasn't really that dirty compared to one that was. So some teeth have different levels, and at a certain point you have to explain to the patient, hey, we did everything we possibly could. Your tooth is just a little bit more infected than the average tooth, but fingers crossed, we got it clean enough to go ahead and do a good job and have it work out for you.
We did everything we could. You just have very dirty teeth.
And that's kind of true. When you have patients that have had bacteria in there for 10 years, going in every odontoblastic tubule and just living in there, numbers. And you can't take offense. You can't be like, think you're not as good of a provider because levels higher or lower. It's just what the tooth and what you're trying to do to the tooth. And that's what I like. It's just a great tool to know how much to clean the tooth and what you have to do. Maybe some patients you do a 2504, maybe some finish the 2504 file. Maybe some patients use 1% bleach, but some patients maybe you have to use a full 8% bleach. Maybe some patients you have to get to an F5. So it just kind of lets you get individualized care in all these patients based on the amount of cellular debris inside of the tooth.
So, Randy, I'll tell a little story for my close, but and I'll look up here at the camera. But anyway, Phyllis started many years ago this program called Ruddle with the Residents. So we were really excited and enthusiastic to receive like West Coast residents from a lot of different programs. And I think I must have said to, I don't know how many classes that came before me, because I've been saying it since the late 1970s, Randy. Why can't we just go out to the pool with a little piece of paper and dip a little indicator into the water and look at the pH and know, do we add chemicals today or are we still good? And apparently you've got us to a place where we can check the pool. So that I'm really grateful for. And I want to tell you, I mean, you're doing something that's going to change the way we practice and approach our endodontic treatment internationally. So for that, we will definitely want you back in the future, and stay in touch with me, big guy, because you know how much I think this is going to change the future of endodontics.
Much for joining us today, and we really do want to follow you on this journey, so we will have you back again.
Thank you guys for having me on. And again, if any of your guests have any questions or want to do research themselves, then just feel free to reach out to me at ddscross@gmail.com. We can get you kind of we kind of get you guys to help out with this new step in the endodontic career. So yeah, thank you guys so much for having me on.
So we have a short Q&A for you, and since the theme of our show today is Game Changers, these questions revolve around that idea. So I'll ask the question and you answer.
Okay.
Okay, here's the first question. I used to routinely do 2-visit endo, but have now started to schedule the majority of my cases for 1 visit only. What is your opinion regarding 1 versus 2-visit endo?
Well, it's a loaded question. It depends on a lot of things. First, do you have the time scheduled to be definitive and to be complete and do quality care? The other thing is, how does our patient present? Are they coming in with swelling? Maybe they have a lot of pain. Maybe the tooth's necrotic. So maybe we could start to talk already about vital versus necrotic cases. So I do 1 visit on necrotic and vital cases. Mainly it's just chair time. I won't do 1 visit if there's acute symptoms. And that could be just a lot of pain with no swelling. Now, if it's necrotic, sometimes you got to get them on antibiotics. You got to get the bacterial load, serum levels up on that antibiotic so that when you do go to work, you have serum levels, blood levels, protection. So other considerations are the case difficulty. And we've talked about that in previous shows, that AA assessment form. But if you see something that's really long, really curved or recurved, and, very calcified mineralized canals, that's probably, their joint might not be able to withstand, their TMJ might not be able to stand a long, long session. So I've mentioned joint, vital versus necrotic, symptoms versus no symptoms, case difficulty, and I think that's the big ones that I can think of right off the top of my head. I'm sure there's others I forgot.
I can think of a couple.
Tell me. No,
well,
good.
I know that on a previous show, we talked about the redundant time of scheduling, the redundancy time when you schedule for a second visit when you could have probably about 15 more minutes.
We did that show. We found out that according to my mentor's 5 partners, 15,000 patients, there was about 30 minutes of non-productive time, redundant time, every time you reschedule the same patient.
And the other thing that I had thought of was from Dr. Cross's presentation, where he pointed out that when he tested the biomarker levels after 2 visits, it was higher than 1 visit. And maybe it's because get in there and more bacteria? I don't know.
Well, you're bringing up another question answer that we won't do today, but it would be 1 versus 2 visit endodontics. And in preparation for this show, I was looking at some of the Scandinavian literature, and there's always about the same 5, 6, 7 guys, really well known, respected around the world. But they basically said that after 1 visit, you can never assure in necrotic cases for sure, even in some vital cases, depending on the level of breakdown, that you could produce a clean canal or system in 1. That led to a lot of Scandinavian emphasis over decades of 2 visit endodontics, and oftentimes calcium hydroxide as the temporary medicinal properties we'd put in the canals between visits. And then, of course, my classmate, Richard Peckrin, in 1981, started changing that whole conversation with his seminal paper in the Journal of the American Dental Association on 1 visit endodontics. 5 years later, in the J, he then wanted to talk about the failure rates associated with 1 visit versus 2 visits, and it was only a very small uptick in more failures, and he had some reasons why. But anyway, yes, Randy showed us that if we had the confidence to be knowing that we're clean, our bacterial loads are below a value that is deemed appropriate, then there's no more guesswork.
Right. He said if it's not clean, just clean it a little bit more.
That's right. And if you run out of time, just provisionalize it. Calcium hydroxide. Bye-bye.
Okay. So the next question. Time since I've raised my fees, and I really should, but I don't want to alienate my patients. What do you recommend?
Well, we talked about the reciprocal part of this problem on a recent show, and we talked about discounts. So, you can Google the Kodak study, the Eastman Kodak study. I learned about this study in the late 70s. It seems like there's quite a few people talking about it, so maybe it's not so innovative. But the Eastman Kodak study said for every $1 that you produce per unit of time, the Kodak study said 75, 25. Just for ease today, I'm going to say about 80% is going to be your overhead. And that means that it'll be about 20% would be your margin to take home, your profitability. And so that would be, $800, and that would be $200. And so the question we talked about last time was what happens if you discount it? And it's way more than the magnitude of the number you're quoting. So what if you raised your fees was your question, did something as little as 10%? Well, 10% of 1,000 is $100, and that $100 goes right over here because your overhead's not more tomorrow morning, the rent's not more tomorrow morning, the staff is still paid the same, the supplies are still the same. They will all elevate with time. We recognize that, but an immediate impact, you raise your fees 10%, crank out an extra 100, you go from 200 to 300. The difference is 100 over 50%. So just by doing something pretty small, you can make an enormous difference.
Right, because I think we talked about on the show that if you're offering a patient a 10% discount, to a lot of patients, 10% seems like a pretty small discount. Like it's nothing to just get super excited about.
Right.
I think likewise, a 10% raise, like if the fee's 10% higher, that's also seems like a negligible amount and nothing to flip out over. So yeah, I think, but it really makes a big impact here. So that's.
The Kodak study also looked at something that you're hinting about. I want the market to hear it. You might say, well, if I raise my fees 10%, I'm going to lose patients. All of a sudden, I'm sitting around reading magazines. No, they did that work too, because they studied all businesses, small businesses in the United States that operated about 75, 20. Dentistry fits right in here. They found out that when you raise your fees 10%, you lose 0% of your patients. When you raise your fees 20%, you lose about 7%. And the 7% you lose are the moaners, the whiners, the gripers, the bitches, and the complainers. It's the ones that your receptionist spends about 80% of her time on. Maybe you want a clean house, raise your fees 20%, and say bye-bye to all you people that are miserable in my practice.
Okay, well, I think we have time for one more question, if the answer is a little bit shorter.
Okay, I heard that.
If I was going to invest in one high-end technology and one more affordable technology, what technology would you recommend that would make a this?
First comment, dentist specific. Because if I interview you and 10 other people, you're going to be at different levels of your career, and what's important for you might not be so important for somebody else. In other words, you might already say, I have a microscope. I got a microscope. I was in the early, that middle 80s thing. I was in that ground-based movement. But then I would say, well, how about CBCT for you? Do you have that? And if you said I don't, I'm going to say you're going to be a much better diagnostician. You're going to discover pathology. And of course, that means you can take care of people in a more profound way. So I would say CBCT and microscopes are great. And then if you said, I need something just kind of low end that'll be a difference changer, well, I'd ask, do you use stainless steel hand files or do you use NiTi? Do you use a big series of files? Or if you really want to get simple, have you ever thought about Wave 1? Pretty much 80% of the time, single file technique. What if you said, we don't have digital and my assistant's going in the rooms and she's gone sometimes for so long I fall asleep. Me and the patient are sleeping. Well, if you got digital, that could really, in 5 seconds, 1001, 2, boom, boom, boom. It's on your screen and you're able to make an assessment and continue working. Apex locators. How about an electronic apex locator? You can get into those for less than $1,000 and it's going to give you more accuracy. It's going to keep that procedure flowing towards success. So those are a few things I could think of.
Okay, well, thank you. I think that we had a great show today. I really was very impressed by Dr. Cross's presentation and him too. And we got to see a major game changer there. And now we've just talked about some more game changers. And
as a follow-up, sorry, but I didn't talk about it when Randy was here, but I know he said a minute, but he didn't say the fee. It's only going to be a couple bucks a patient. So there's a cheap, ineffective, a very powerful, effective way to know with certain amount of investment.
Yeah, that's actually, if you think of everything we talked about today, the cost of that, and then the result you will have, that's definitely a game changer.
I'm really excited about that.
Okay, well, that's it, and we'll close after this. We're going to close today with a segment we call Cast Perspectives, and it's going to be a little video where all 5 of us who work to create the Ruddle Show will give you a little insight into how we think about shooting the Ruddle Show or maybe issues that are important to us. So we're going to watch that video now, and we hope you enjoy it.
I hope you learned something from the Cast Perspective.
So see you next time on the Ruddle Show. So we just finished filming our game-changing episode and saw some exciting new technology, but it's not just this episode. We are always locked in on trying to find new ways to make a difference, whether it be talking about AI, new technology, technique tips, maybe trying to give you a fresh perspective, or even strategies on how to have a winning attitude. So keep watching, because we promise you at some point we're going to say something that might just make a major difference in your life or practice. It's basically us challenging ourselves to be the best we can for all of you.
I love having a guest on the show. I have all these people in my mind from all over the world that I got to get on the show. I have a big queue of them waiting patiently to come on the show. But what I get to learn is from the experts. And when we have somebody on the guest, they're usually bringing something that Ruddle can't do, is deficient in, and there's somebody much better than me to do that. So having the guest on, I learn from the guest, and each one is different in their own way, and it takes me right out to the cutting edge of what they're thinking about.
You may ask, what is the major job I do on the set? I come in, I try to be quiet. I've been critiqued for that. But my main job is keeping everything stocked and running smooth. Toilet paper, paper towels, water. Do you need to buy something? Oh, it's a write-off. Great, let me know. Thanks.
What would I say is a personal challenge working on the Ruddle Show? That's definitely balancing all of the emotions and the temperaments that we have. Working in a family business is the best, and but it also can be extremely what's the right word, dynamic and stressful because you want to maintain relationships while at the same time foster creativity.
So one thing I do every about 2 or 3 seasons is I create a new opener for the Ruddle Show, and my mom helps me brainstorm. And this time I actually tried to involve pretty much everybody in it. And pretty much every single time I learn a ton about how to build like a composition and put audio with music and visuals together nicely and stuff. So very good learning process for me.
How is it working with family? It's the best and the scariest. I tend to be the peacemaker in most situations. Try to talk it through quietly, but if it escalates and there's yelling, then I have to go hide somewhere, and I need to work on that.
So I find it very challenging to figure out what to wear for the shoots because I want to be professional but not boring. So Isaac and I joke that I aim for capital attire from the Hunger Games. So those of you who know me personally know my style is a little bit eclectic. So I try to choose something that is interesting, but hopefully not distracting.
Well, you're probably thinking, what critique would Ruddle get from his family? Because I'm surrounded by all these family people and all the dynamics, differences in ages, personalities. They said to surrender because they said, being an endodontist and probably type A and having my hands and fingers on all the levers and dials, they said to surrender, shut up, and do exactly what they tell me to do.
I know the clinical footage is relevant, and we've built a whole just-in-time library about that, and we do that all the time on the Ruddle Show, but I'm always encouraging the group here to get out of the studio, outside, somewhere in Santa Barbara, the wharf, or really anywhere for that matter outside of the desk sometimes, so that you can see Ruddle and Lisette in a place that they're not usually seen. And it also makes it very interesting, and you get to learn a little bit about how they operate outside of the studio set. Maybe seeing Cliff and Lisette doing some sort of sporting event together. That would be fun.
You ask, what are the anxiety issues for me on the Ruddle Show? Because I'm pretty laid back. Getting Cliff's computer set up and the pre-launch day when Lori and I are at the office getting everything uploaded. Lori does most of the work, but I'm there too, and I'm so happy when it's all done.
People think that a lot of times because I'm an endodontist, I can just get on the show and give a few lectures, and he's been giving lectures for 45 years, so that's got to be a piece of cake. Even that's not easy. In fact, one of the things I like the most is the learning part. So when we do all those little segments, a lot of times like on artificial intelligence or augmented reality, I'm learning.
What's one of the hardest segments I had a hand in shooting? Definitely this one.
So one of the biggest problems I've had on the Ruddle Show is audio. At first we were using lavalier mics, which had great audio, but were really hard to set up and had a lot of static issues. So we switched to boom mics, which pretty much have the same audio, but maybe not as good, but they're way easier to set up and completely out of the way.
What are my favorite parts of the Ruddle Show? Well, I have to say my favorites are the outtakes that we do, the silly things that we capture here and there. I still think we should capture a good old family fight. Those are my favorites.
Timekeeper, that's my job on the set. So my perspective on being a timekeeper, you have to have a really loud voice so people will listen to you. But I find that there's a lot of loud voices on the set, so I just have to always try to be the loudest.
So my dad, or shall I call him the GOAT, he's always the first to arrive and the last to leave, every time.
What's the very first thing Ruddle does when he enters the studio? I get the Hoover. I'm a permanent vacuum man. Everything has to be pristine because the staff is arriving and we have to set the decorum. Has to be excellent.
So there was that one time where we thought we lost shows 1 through 4, but I was able to recover it from the corrupt drive, thankfully. I should probably mention it was a whole week later. It was very stressful.
So apparently the plumbing at the studio runs maybe slightly uphill, so the toilets never flush very well.